physician adoption. One thing that Jeff is working on that's very interesting is a clinical decision support tool for physicians so that they can really have the information they need to make the decisions about how to deploy some of these technologies you've heard about tonight at the bedside. So take it away.
Well, after about an hour of hearing talks, I'm going to go fairly quickly. My name is Jeff Shomaker. I have a small company, 21SP. We're developing handheld software tools for physicians to use at the bedside. And hopefully we'll get pharmacogenetics incorporated into general clinical practice. There we go. Yeah, that's a good idea.
Much better. Thank you.
So we're just going to go quickly through about 4 slides, and then I'll do a demonstration of the software. That's interesting. That's right. There we go. Thank you. Okay, as I said, it's a small company. The software that we developed is to use pharmacogenetic information to dose warfarin. And basically, the main message to take away from this slide is that many studies have shown that warfarin is effective if you keep the INR level, which is a measurement of how fast a person's blood coagulates. If it's very low, then they're likely to have blood clots, strokes. If it's very high, they're likely to have bleeding. If it's over 3, it's likely to be bleeding in the gastrointestinal tract. If it's over 4, it increases the risk of intracranial hemorrhage bleeding, and roughly 50% of those folks, it's fatal within a month. Basically, what we're all about is, well, let's just go through a quick example. Pharmacogenetics helps to explain how people respond to drug therapy. And atrial fibrillation is a really good example. It increases stroke risk 4 to 5 times. Warfarin has been around for 50 years, and it reduces the risk of stroke by 2/3. So many people in the audience probably know folks, a lot of people in America over 65, 70 take warfarin. My mother's one of them. About 2 million people start warfarin each year. However, during the first 6 months, there's many adverse drug reactions. Roughly up to 25% of people will have a stroke or a myocardial infarction, and up to 20%, 15 to 20% of those people, those 2 million people that start, will have to be hospitalized because of a bleeding event. Most of the time they're not fatal, but they're fatal. Half of them are fatal if they're intracranial hemorrhage. We've developed a tool that's practical and cheap and easy to use to guide physicians, even if they're not experts in pharmacogenetics. We're going to use Dave Duncan. I think he was supposed to be here tonight. I don't know if he's here, but we're going to use his genetics. He's a popular person for presentations. And basically, he's given me permission to use his genetic characteristics to demonstrate the software. He's very sensitive to warfarin. And his genetics are up on a SNPedia database, a public database. The proper dose for him would be something like 2.5 milligrams a day. The standard starting dose in America is 5 to 10 milligrams a day. It would substantially, and many studies have shown this, substantially increase the risk of him having a bleeding event. So finally, a very large study, a very high quality study was published in March this year. And I'll just quote, highly superior to pharmacogenetics-based dosing was highly superior to standard dosing in comparative effectiveness in achieving or maintaining the therapeutic INRs. As we saw on the first slide, it's very important to maintain the therapeutic INRs. If you get out of that range, it increases the risk of disability and death. And pharmacogenetics-based dosing basically reduces bleeding events and thromboembolisms, stroke or myocardial infarction, and it saves lives. It's been proved beyond a doubt. And our tool is very easy to use for general practitioners, even someday, probably in the future, nurse practitioners, maybe RNs, who knows? But the idea is to have a tool that steps a physician through the process even though they're not an expert. There's only about 25,000 cardiologists in America, and of course it would be great to have one for everybody, but if you're in Montana or some area in Maine or Appalachia or India or wherever, most of the time you don't have access to a cardiologist. Okay. And we'll just go into a demonstration here. Here's the software. It runs right now on a Samsung Android. It runs very quickly. It goes a little slower now because it's going through a simulation program. And this stuff on the right, you won't see, of course, on the phone. So we'll just pretend that we're using David Duncan's genetics to estimate a dose. And basically, the software it's kind of like a small book. It includes information from published clinical guidelines, published in the Chest journal. It has drug reference information from FDA-approved drug labels. It has many, many references to pharmacogenetic-based papers and diagnostic test information. So we'll just pretend we're going to start somebody on warfarin. And we'll say initial dosing. And we'll say, Dave Duncan, he's told me he's 54, and he doesn't have any other issues. So the general way that physicians, basically the standard of care right now is that patients will be started out at 5 to 10 milligrams a day for a couple of days, and then they do this INR test. It's a small blood test. As I said, it measures how fast blood coagulates. And the target for atrial fibrillation, at least, we'll pretend he has atrial fibrillation, is usually 2 to 3 unless somebody has a heart valve. But in 2009, we can see at the bottom of the screen, New England Journal study paper co-authored by a couple of professors at Stanford that I reviewed this system with, came out and said that for roughly half patients, the standard way of doing it, or traditional trial and error method of doing it, is not accurate, and you can do much, much better, and I'll show you how. So we'll back up, we'll go back to don't have to go that far back, so we'll go back to the main screen, we'll just go down to pharmacogenetics, and there's two ways to do this. This is the algorithm that's been tested in something like 5,000 patients. If we're a standard person, I can't see. Anyway, we'll pretend initially that David Duncan doesn't have any gene variants, and we'll just say he's 1 here, we'll say he's 1 here, basically a standard person. He is 54, he told me. Gotcha, thank you. And I have a little trouble seeing the keyboard. There we go. Oh, thank you so much. That's great. And he's 6 feet tall. And for our purposes, he's 6'0". This calculates the body surface area, which is important in cancer therapy, but also in some heart disease. And he says he's 190 pounds. He does not take, this is an antiarrhythmic drug. He doesn't smoke. He does not have deep vein thrombosis or pulmonary embolism. We'll say his target INR is 2.5. There we go. Interesting. It's much easier. And he is not of African origin. So the dose would be roughly 7.2 milligrams a day. You can see the average, the sort of standard starting dose, I don't know if it's proper to say average, but the standard starting dose in the United States is 5 to 10 milligrams, so it's 7.2 milligrams. Very small difference. So let's just back up and quickly go through him with his true genetic characteristics. And he is a TT for, whoop, here we go. He is very sensitive on the drug target, so he has to have a much reduced dose. He doesn't have this particular variant. He's intermediate in the CYP2C9 variant. He's still 54. He's still 6 feet tall. He's still 6 feet 0. He's still 190. He doesn't take any additional drugs that would influence this. He doesn't smoke. He doesn't have that. 2.5. Not African origin. And so, does anybody want to guess what his dose would be? It's very sensitive. Okay. There it is, 2.5. So David Duncan, and it's impossible to tell. It doesn't matter, it's just impossible to tell. One person in the room could need 1 milligram per day to have the proper dose to maintain that INR range of 2.5. Another person sitting beside you could need 20 milligrams a day to maintain the INR of 2.5. So nobody can tell. You need to do a pharmacogenetics dose based for warfarin. Warfarin is a life-saving drug. It's a cheap drug. It's like $300 a year compared to the newer drugs that are like $3,000 a year. It just is a very tricky drug to use, and one of the goals of my project is to help educate physicians out in the clinic that this is something that's very easy to do. Currently, the test is only being done. There was a recent, I've seen the data on this several times. A recent study said that about 4% in Minnesota, some people did an analysis of data from Blue Cross, Blue Shield, and some pharmacology benefits organization. And so they think about 4% of people are being tested, 4% of the 2 million people, if you extrapolate it out to the United States population. So maybe 4% of the 2 million people are being tested before prescribing the dose. And the average cost of the test now is about $150. And turnaround times are 1 day, maybe 2 days. And probably at some point in the future, people are talking about a matter of hours. So it's a very simple thing to do, but it's very important for the patient. So with that, I'll just say, I'm not sure how much time we have. I think I might have used up all the time, but does anybody have any questions?
I have one. How do you factor in drug interactions? You know, Coumadin is notorious for multiple drug interactions. Is somebody taking
yeah, there's there's a whole list of interactions in the system. The system will guide the physician. It's just in a different area than what I showed you just because of lack of time. There's 110 different screens on this. It's intended to be an expert system that will guide anybody with some medical knowledge in understanding how to dose the drug properly. If somebody has to go into surgery, you know, when do you stop? Do you stop 5 days before surgery to give a person vitamin K, which is an antidote to warfarin, and it lists the drugs that basically would alert the physician to the fact that there's a whole list of drugs that would make warfarin, would enhance warfarin's effect, to make it more likely somebody would bleed. There's also a whole list of drugs that retard warfarin's effect, make it more likely that there would be blood clots and strokes. So it's in there. We're glad to show you after the break.
So the prerequisite is to have the gene expressions for the patient? I mean, what is the
minimum? You have to have a genetic test done. And on average, at least in Minnesota, it's about $150. Some companies will turn it around. Kimball Genetics in Denver will turn it around in is the video with Nature. In a big study at the University of Utah recently, I'm not sure, what precisely how they did it, but they had to turn around in just a few hours to test. So on the drug label, it says if you don't know genetic information on the FDA-approved drug label, if you don't know genetic information, start a person at 2.5 to 5 milligrams a day. And so then you might have the test the next day and be corrected.
How many medications do you have in your kit?
Right, this is our first product, and it's not on the market yet. It will probably be in the market in the next 2 weeks to 4 weeks, in October sometime. This is just working.
Okay.
But we're planning on using this model for a whole range of medical decision making.
How will the pharmacy provide these customized doses? Like, let's say the person needs 1.2 milligrams as opposed to what they start out as.
If it's 1.2 milligrams, I don't know what the person does. They'll just have to, the physician will have to recommend the dose.
Get it 2.5 and cut it in half.
And that's how it's done now. I mean, they break it, at least one person on the warfare told me, break it in 4 pieces. So it's not 100% precise, but it's still way more precise than is traditionally done.
Jeff is going to be around to answer the remaining questions. Looks like there's a bunch. So thank you all for coming tonight. And
thank you very much.